Good morning. I am patient Atumanya, and I'm going to be talking about critical care in Uganda, history, and an overview. I don't have anything to disclose at the moment. Yeah. So if we look at critical care in general, critical care medicine, it's one of the new branches of medicine that have come up. And for the most part, it deals with provision of care to critically ill patients that tend to need intensive and specialized medical and nursing care. And the aim of all this is really to kind of sustain the organ support until these patients are healed. And for the most part, we tend to use life-sustaining materials or equipment and that kind of thing. Now, when you look at Uganda, we will use the definition of what we'd call probably an ICU bed as one that has a ventilator, has a suction machine, and also utilizes the standard ASL monitors, a nurse with the presence of a physician, either an anesthetist or an intensivist of internal medicine background. When you look at the history of ICU in Uganda, the first one was in Mulago National Referral Hospital, and this was in the mid-90s. And then they had renovation of the old units, and this was donated by the Chinese government. And also the nurses were majorly trained by the Japanese to kind of lead this ICU. We initially had 12 beds, and they were led by a British trained anesthetist. And then you fast forward from the mid-90s now to 2007, when we started having the private ICUs, LACHO and IHK, and they were all led by anesthesiologists. When you look at 2012, I think this was our first time to have a look at the number of ICUs that are available in Uganda, the bed capacity and where they are located, that kind of thing. And this was done by Arthur Kwizera. This was in 2012. And at that point, we had 8 functional ICU beds, 8 functional ICUs. And as you can see, about 37.5% were in the public sector. Although in this study, UHI was classified as a public institute, yet you could easily classify it as a private institution, even though it's in a public institute. When you look at that point, we had 36 ICU beds for the entire country, which would, tally to about 1 ICU bed per million population. 62.5 of these were still located in the central area, and about 50% are still in the private sector. With Ginger at that point not being functional, as much as the beds were there, they were not admitting patients. Now, over time, of course, we've had an increase in the number of ICUs that are available, an increase in the anesthesiologists, and we've also had some input from the physician intensivists that can help with the running of these units. Now, in 2012, we looked at a study that was kind of assessing the current capacity of ICUs in Uganda. It was a descriptive study. And at that point, we found that there were 12 functional ICUs. And if you can look at this, you'll find that about 80% of them are located in the central region, with only 2 that were in the peripheries, that is the functional ones. That's LACHO and BARA. Now, we also had 2 still well-equipped and all that with space. But at that moment, they were not admitting any patients. And this was in Ginger Hospital still and Lira. Now, you fast forward to about 2020 or 2019, towards the end. And this is where we have that is 2020, where we have the COVID pandemic. And of course, the need for ICU beds was really massive. And as part of the government initiative, they equipped about 14 all the regional referrals with ICU beds, and the plan was to have at least 10 beds per regional referral, and these were put in place. Unfortunately, as much as we have the ICU beds there, most of them are not as functional. Now, on top of this, we also had an increase in the number of private ICUs, and most of them were actually in the central region, and those are the ones which are depicted in green. And that has kind of boosted the number of functional ICUs that we have in Uganda currently. And this is really anecdotal data. We have about 30 functional ICU beds. That's inclusive of both private and the public. Of course, the privates have been kind of increased more than the public, but at least we noticed that there's been great strides taken by the government to kind of increase in the number of ICU beds that we have. Majority of which are actually in the Mulago Hill. That is, we have Women's Hospital, which also started getting functional. We have the 28 COVID ICUs, which are 28 beds, I think. Then we have also a strictly pediatric and neonatal ICU. Still, all these are on the Mulago Hill, which is really a big step towards increasing the critical care capacity in Uganda. Now, for the most part, we don't really have a standard of how these ICU beds should be set up, and for the most part, it will be based on the anesthesia provider or the physician intensivist to kind of dictate how the beds are set up. So this is still from the study carried out in 2020. And we're looking at the bed separation. For the most part, about 42% of our population, of our ICUs have walls separating the different ICU beds. You have about 33% having curtains separating the ICU beds, and for the most, the small percentage, they are open space ICUs. The floor space still, we noticed that it was not standard when you compare it to the say the Americans or the Europeans. We fall short because much of our ICU space is really small, about 67.8 square feet per bed. We found that about 25% of the ICUs had an isolation room, which is pretty scary, or more of a misnomer really, since we have more of these infectious diseases, contagious diseases. You'd anticipate that we might have more isolation rooms compared to the rest of the communities out there. About 80% of these ICUs at least had piped medical gases, but we noticed that this, as much as they had the medical gases, most of them just had oxygen without, say, medical air or any other that might be needed. And almost all the ICUs had a backup generator. When you look at the staffing, for the most part, I think because of the training that the anesthesia, the physician anesthesiologists experience, we have critical care as part of the curriculum. 75% of our ICUs are run or headed by physicians with an anesthesia background, and about 25% will have internal medicine background. We've not seen yet some of the leaders of these ICUs having either surgical or any other of the specialties. As much as that would really be great. We looked at the percentage of this the cadre that are in the ICUs to look at the super specialization, that is in intensive care medicine, where you go for a fellowship after your master's, and about less than 2% had a super specialization in the ICU. Now, when you go to nursing, for the most part, about you'd say more than 90% of nurses are informally trained or formally trained on jobs. with only 7.6% having gone ahead to have formal training in critical care nursing. For the majority of the ratios, nurse to patient ratios, they'll probably be less than 1.2, and this was pretty worse in the public sector, where you find you have about 1 nurse for 8 patients in most of the public hospitals. Though that shouldn't it might be easy to confuse the private sector as having really good nurse patient ratios, though we notice that that might be skewed because of the size of the ICU beds, where you find, you have a 2-bed ICU, you have a 4, the chances of you having, very horrible nurse patient ratios is not as easily achieved as you'd expect. Now, the cadres that we have in the cadres that we have in the ICUs, for the most part, it will be at least all the ICUs had 100% had anesthesiologists participating in the management of these patients. We had medical officers rotating in these areas. We had medical officers providing some kind of support. We had physiotherapists. Sometimes they would have walk-in clergy. We also had anesthetic officers in some of the ICUs where they would they provide at least the airway management to areas where that was lacking. Of course, there will be things like respiratory therapists, which we didn't have. In-house pharmacists, those were pretty rare, and most of the areas actually didn't have them. Now, when you look at the patients that we have in our Ugandan ICUs, a majority of them, you find, for most of the studies that have been run from, if you look at maybe from 2007, the first being in Lacho, you notice that more than 50% of our patients are males. And probably that might be because the majority are also trauma patients, and the males are always more daring than the females. We have a generally young population with an age ranging between 22 to 42 years of age. The youngest that we had was in northern Uganda, that's in Lacho, where they had the youngest median age reported. Most of our patients that are admitted in these units are Ugandans, more than 80%, though we are seeing that the number of foreigners is also getting higher, especially from the surrounding areas like South Sudan, where they tend to send most of the patients down into Uganda for further management. More than 50% of the patients are also surgical, with the majority being trauma and more commonly neurosurgery. And then also the post-operative patients they make up the biggest composition of our ICU patients. A majority of our patients are admitted from the operating rooms, about 30%, and we found that about 27.7 are admitted from the wards, with 22.6 admitted from the emergency department. And I suppose this kind of speaks about the emergency care in our area that we have. For the most part, you find most of our hospitals don't have a properly functioning emergency department. But this seems to be also getting better with time. Now, we also realized, this was the study that I looked at in 2018, and we found that we are seeing more of the comorbidities amongst these ICU patients. About 61% had at least one comorbidity, with hypertension as the commonest comorbidity reported, about 48.6. Diabetes was the second, and HIV at 9.7%. However, we also noticed that only about less than 50% of the patients admitted in these ICUs, even though we are in an HIV pandemic area, less than 50% had an HIV serology test done. So perhaps the reported prevalence might not be as accurate. For the most part, most of our admissions are, if you look at medical versus surgical, the biggest percentage, most of our patients, when you look at the charts, you find that a big number was admitted due to acute respiratory failure requiring mechanical ventilation. Altered mental state was the second one reported. Sepsis and septic shock at 22%, though we also noticed that most of the patients, even though when you look at the parameters for sepsis, diagnosis of sepsis, most of our patients were not recorded as sepsis or septic shock. And then a small percentage having cardiovascular accidents, and at number 5, we have patients who are admitted for post-cardiac arrest management. When you look at the surgical disciplines, neurosurgery took up the biggest chunk of patients admitted, abdominal surgery as the second, and cardiac surgery. And this is probably because we included a strictly surgical, post-cardiac surgical ICU that is at UHI. And to our surprise, we noticed that we actually didn't have such a big number of OBS and GYN cases, but commonly because the cases are not usually as critical as we'd expect. So I looked at the mortality, the ICU mortality trends from 2003, and we noticed that most of the mortality in ICU has generally been above 30%, with the lowest recorded in 2020, and that is the study by Atumanya. It's still unpublished, and the lowest mortality we had was 25.6, although the study was done in 2018. So that's the lowest we've had. The thing could be because this included both the private sector and also the public institutions. We noticed that the public tend to prefer to admit the post-operative patients just because of their survival benefit. If you're going to tend to triage to a highly demanded bed, then you're likely to take patients that are more likely to survive. And then we have the 2019, the highest mortality reported was 52.5. This was in 2015. However, it's highlighted because this was done by Arthur Quizera, and this was looking at, it was strictly patients with kidney failure. And in 2018, this is 2019, sorry, it's also highlighted. This is a study that was also done in a particular cohort of patients that is mechanically ventilated by Irene Chamumi, and this was at 39%. And then we fast forward and look at the COVID area, which was in 2020 to 2021, and notice that most of our ICU patients, the mortality literally skyrocketed than 80% of patients dying in the ICU, with some ICUs recording a mortality rate of actually up to 100. But this is anecdotal and no one should really on that. Yeah. So let's look at a bit of the antibiotic practices. Still, this is an unpublished study from Atumanya that was done in 2018. We noticed that 85% of our patients receive antibiotics, with the commonest being cephalosporins, imidazoles, and carbapenems as the third most commonly used antibiotic. Now, when you look at the study that was done by Agawa Peter, looking at the nosocomial infections and their antimicrobial susceptibility patterns in ICUs in Uganda, he found that the commonest isolates were Klebsiella pneumoniae at 30%, Acinetobacter at 22%, and Staph aureus at 14%. And surprisingly, the multi-drug resistant species were at 58%, with E. coli and Klebsiella pneumoniae being ESBL. And this is pretty surprising because this was published in 2017, and then in 2018, we still have patients who are getting more of cephalosporins, majorly ceftriaxone and metronidazole, which kind of begs the question of, are we really following the studies that we're doing, or are we actually looking at our local antibiograms to kind of change the practice that we're having? All right, so now for the most part, of course, the ICU is meant to provide some bit of organ support. The commonest support mechanism that is, mostly provided in these ICUs is majorly the mechanical ventilation. And in 2020, we had 55 ventilators that were functional, or 55 ventilated beds. However, with post-COVID, we've had a drastic increase in the number of ventilators. If we look at the regional referrals, at least we are certain there are probably about 100 ventilators. Then plus the Mulago Hospital Hill, which had a bump of probably up to even 40 ventilators, with also the private hospitals adding on to the number of ventilators they have. However, we'll still need to kind of ascertain how many of these are in use, how many are being utilized by patients to kind of conclude on how far we've gone. The renal replacement therapy in Uganda is still low to moderate, especially for the critically ill patients. For the most part, or the majority of hospitals are going to have IHD, which is not really well tolerated by the patients that we have. And the best would be probably a CRRT, which is not as commonly available in our hospitals. And for some of the units, they actually utilize peritoneal dialysis. And I think this was majorly in Heart Institute and Mulago unit. When you look at the cardiovascular support, majorly you'll find it's inotropes or vasopressors that are being used to kind of support the cardiovascular system for these patients, except for the Uganda Heart Institute, which is able to do at least IABP for supporting patients with left ventricular failure. I think that's what I can talk about for ICU. Thanks for listening. At this point, I will welcome questions. Thank you.